From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the web and social media editor for JAMA Surgery. Today, I'm talking about the comparative safety of robotic-assisted versus laparoscopic cholecystectomy with Dr. Stan Kalata.
Thanks so much for the opportunity to share our work.
And then I also am here today with Kyle Sheetz, who's an assistant professor of surgery at the University of Michigan.
Thanks for having us. Happy to be here.
Looking forward to talking to you all about this work. It was very interesting to me. I always like to start with origin stories on these studies and why people got interested in their research questions. So why did you two think that it was important to examine the comparative outcomes of robotic-assisted versus laparoscopic cholecystectomy?
So there's generally a lot of excitement around the use of the robotic platform for cholecystectomy. It's not particularly unique for this procedure. The United States performs more robotic surgery than all other countries combined. And in terms of procedural volume growth in the past decade, general surgery has actually been the field that has the most growth. And there's a multitude of reasons that have been attributed to this popularity rise. Surgeons are certainly interested in pushing their skills and learning new techniques, both for the incremental benefit of the patient in front of them, but for future patients as well. And the robotic platform definitely has technological improvements over traditional laparoscopy. So there's improved visualization with the camera. There's some novel ways to visualize biliary anatomy. So theoretically, the hope would be that procedures can be safer for patients with this technology. And there's also inheritance assumptions from the lay public and patients themselves that this new technology will automatically result in superior outcomes. However, we know that outcomes for novel procedures tend to improve with increasing experience, and we saw this phenomenon play out decades ago with laparoscopic cholecystectomies when they were first introduced as an alternative to open surgery. So the initial practitioners of laparoscopic cholecystectomy criticized for higher rates of complication, including bile duct injuries. But since then, there have been decades and decades of hard work focusing on performing safe laparoscopic cholecystectomies among both already practicing surgeons and for new trainees. There have been focused initiatives from our own surgical societies, such as the Safe Cholecystectomy Program, and then training in safe laparoscopy is a robust part of any general surgery training paradigm. So with the diffusion of expertise in laparoscopic cholecystectomy, it's resulted in improved overall outcomes for patients when compared to open, but it's unknown whether the same holds true for robotics. So we set out to perform a comparative effectiveness study of these two already minimally invasive techniques. Because, when you think about it, the incremental benefit to patients may not be as robust as the transition from open to laparoscopy, but the skills required to transition from laparoscopic to robotic approaches may be more easily transferable than from open to laparoscopy. So with the adoption of any new technology, it's also important for us to think about comparative outcomes, not only for the high volume centers who have a unique expertise and are responsible for pushing technology to its limit. We also have to step back and take a look at how new technology is performing in the real world. So this lets us sort of understand not only what the outcomes are between the two techniques, but lets us think as a field much more clearly about what problem that new technology is trying to solve. So specifically, the question always remains whether technology or new technique should be a niche offering for a subset of patients or only performed by a particular group of surgeons, or whether the technique should be disseminated more broadly so that one day it becomes the standard of care. So when we were thinking about this question, we came out with a primary outcome of a true technical complication on the surgery, specifically bile duct injury that was severe enough to require an unfortunately highly morbid operative reconstruction. So while comorbidity burden can make cholecystectomy or postoperative recovery more difficult for some patients, the causes of bile duct injury have been pretty well studied, and it's most likely a result of operative decision making. So namely, difficult dissections and the inability to identify critical structures to perform this procedure safely have been implicated. So this would be the exact technical outcome to think about when you're trying to compare whether a novel technique is better or worse than the current standard of care.
For the purposes of this study, you all used a decade of MedPAR claims data, so Medicare claims data. Why did you select that particular database? And I was also curious if there was a reason you chose to exclude patients who were enrolled in Medicare Advantage.
So we use Medicare claims data since it's a robust population-level data set that lets us capture real-world long-term outcomes after cholecystectomy. So having a decade's worth of claims data, we're pretty confident in our ability to capture our main outcome of interest, which is the presence of a bile duct injury that required an operative reconstruction within a year. There's not many data sets that allow us to capture this longitudinal outcome at a population level. We don't currently have access to Medicare Advantage claims data, so we excluded these patients from our study. We, frankly, don't think there's any reason the outcomes would be any different for this cohort. Certainly a different cohort of patients in terms of comorbidity burden. But our group has actually recently published work that found that the uptake of robotic surgery for general surgery procedures outside of cholecystectomy was similar between Medicare fee-for-service beneficiaries and privately insured patients. So we don't suspect the uptake for this patient population would be any different. And we don't suspect anything anatomically or any reason that their comorbidity burden would be different and the results of our study not be generalizable to them.
The other thing to think about is everyone essentially has to accept Medicare patients. And so it allows us to capture a very broad range of surgeons and hospitals, which is important when you think about the real world outcomes of any two procedures. Is, are you capturing a reasonable sampling of the country and the practice patterns of surgeons in different settings? And Medicare is a great resource for studies where you really want to capture what's going on all over the country, not just in academic medical centers or community hospitals.
I would love to have a slightly nerdy statistics moment with you all. Can you please explain why an instrumental variable analysis, such as you all used, might be employed in a study like this and the impact of that type of analysis on your findings? And were there other instrumental variables besides the ones that you used that you considered for this study?
Yeah, I think the idea behind using an instrumental variable analysis is actually from an immediately clinical question. So a surgeon might look at this study and say, well, there's things that you're not capturing in claims data that are going to be really important to determine what patients have a bad outcome or a different outcome than others. And those may be systematically different between someone that got a robotic surgery and a laparoscopic one. And what an instrumental variable analysis allows us to do is account for both the things that we can measure in the claims data, so whether someone had diabetes or not, and other things that are unmeasured. And what instrumental variable analysis does is, instead of randomizing patients 1 or 0, like a clinical trial, patients are partially randomized to either robotic or laparoscopic cholecystectomy. But when you extrapolate to the population level, it gives us an estimate of what the differences in outcomes would be for a patient who'd be considered a candidate for either operation. Again, accounting for things that we can both measure, like diabetes, and can't measure, like they've had prior operations and it's a tough dissection. And so the important thing is the clinical interpretation is actually a useful one in this case, which is that a patient that would be a candidate for either operation, not someone who'd be a great candidate for robotic surgery but got a laparoscopic one, or vice versa. And then as far as using specific instrumental variables, the tricky part of an instrumental variable analysis isn't necessarily doing the math, it's planning the instrumental variable analysis itself. And there's all sorts of conditions that these variables have to meet. In general, what you want to do is make sure that whatever you're using as an instrumental variable isn't directly related to the outcome itself. And so you have to go to careful lengths to figure out what instruments may be suitable. So here we used essentially the regional use of robotic cholecystectomy in the year prior to the operation. You could use other things like hospitals or the region's overall uptake of robotic surgery. And there's ways to test how specific or how useful those instrumental variables may be. And we ultimately opted for this one because it seemed to both work on a kind of conceptual level and then also mathematically was found to be a rather strong instrument.
That's great. Thank you. I learned quite a bit about instrumental variable analysis very quickly. I want to start with the patient characteristics for your study. And I'm going to lead with the fact that robotics has not yet made it into burn surgery, which is my area of specialty. So I'm pretty naive about the use of robotics. I was almost immediately struck by the significant difference between the laparoscopic and robotic-assisted groups in terms of their comorbidities, with the patients in the robotic-assisted group generally being more medically ill at baseline than the patients in the laparoscopic group. Can you give me an insight into why a robotic-assisted procedure might be preferable for patients who have a worse baseline health status?
So we agree that the robotic-assisted group had a higher comorbidity burden based on the things that we measured, and there may have been some selection of higher risk patients for this technique. But importantly, in our study, we found that there's no significant difference in overall complication rate between these two groups. So the major differences that we found were in our primary outcome, which was a technical complication. It's important to recognize in terms of these baseline characteristics that robotic cholecystectomies were also more likely to be performed in elective settings and also less likely to be performed for acute or chronic cholecystitis. These two conditions would be considered conditions that would make the operative dissection more difficult, more likely to result in misidentification of critical structures, and could lead to a common bile duct injury. So this suggests that surgeons may be using the robotic technique for higher risk patients who are undergoing elective cholecystectomy, the idea being that this technology may be allowing them to perform more complex maneuvers and get patients through the operation more safely. Unfortunately, we did not find that in our multivariate analysis, and this type of selection bias is exactly what is addressed by our instrumental variable analysis that we talked about before.
Oftentimes when you're doing these studies, the direction of the selection bias is clear, meaning someone is experimenting or using a new technology and they're going to use it on more simple cases because they want to get used to it. Here, the idea is that some surgeons may actually think that this is a useful technique for their hardest cases. And so when you are approaching the study at the beginning before you've even gotten to the results, it's a little unclear whether the robotic group is going to be biased towards having worse outcomes or better outcomes. You could make an argument either way here.
I was also fascinated by the racial ethnic disparity and that both Hispanic and Black patients were more likely than their peers to undergo a robotic-assisted procedure. And that, of course, got me thinking about if there was a role that health equity was playing in all of this. Do you have any hypotheses about how health equity may be impacting what you found there?
So we don't have a great answer for this one. We suspect that the hospitals that serve these patient populations may have had the opportunity to access this new technology over the past decade. And this sort of the phenomenon is that once this technology is available, it becomes disseminated pretty quickly. So prior research from our group found that for robotic colectomies, for example, once you adopt a robotic-assisted technique, there typically is an associated 2-to-1 replacement of laparoscopic techniques over open ones. So we suspect these patient populations may have just gotten access to this technology in this past decade. And importantly, we don't think there's any differences for these patient populations that should result in increased technical complications from this operation. So we still believe that our findings hold true for these patient populations as well.
You all did have a robust set of robotic-assisted cases for inclusion in the analysis, but I still found the curve in Figure 1 to really highlight that the uptake of robotic-assisted cholecystectomy really hasn't been terribly rapid by what I was seeing there. What barriers are there to this process? And is this something that we should be pursuing more aggressively, or is it something that we need to continue to approach thoughtfully?
So we found a 37-fold increase in the utilization of the robotic platform in the past decade. So it's about 5% of cholecystectomies performed in 2019. And the biggest barriers to the continued uptake of this technology are certainly cost and access. And while our analysis and study focused on postoperative outcomes, prior studies have demonstrated that the robotic technology is certainly more expensive to use, requires longer operative times to complete an operation, and requires specialized operating room staff to assist with an operation. There's a lot of upfront investment to even get access to technology. Surgeon access to this technology is also necessarily going to be limited because it's so expensive within their own institution. So it's typically shared among a diverse group of providers in a hospital with various needs for block time. So it's not something that can very quickly or easily be accessible by practicing surgeons whenever they like it, and that likely won't change anytime soon. So this is in contrast when you think about the laparoscopic approach, which requires a lot less upfront investment to successfully perform in a typical operating room. So there are arguments that it would be necessary to continue to push this technology to overcome the barriers that we mentioned before. If the technique definitely resulted in improved outcomes, but unfortunately, our study did not find that conclusion. So at a population level, including our instrumental variable analysis, these results suggest that there should be a bit more caution when you think about providing this technology and appropriate barriers and safeguards to ensure that robotic platform is being used safely. These are certainly things that have been discussed prior, and certainly opportunities to improve the care of patients and try to understand what the appropriate use case for this technology will be.
When you think about when is a good time to do this study, it's now, because there are other operations. This is just as an example, but think about prostatectomy. The proportion of cases done robotically is far in excess of any other, open or laparoscopic. And so to try to reverse course or make any clinical nuance change in practice, not that it's needed there, but just it would be impossible because that is the standard of care. That is the practice pattern. Right now, what we're seeing is a sharp increase in robotic operations, but it isn't the dominant mechanism by which patients have cholecystectomy. And so we have this chance to think about what we're seeing is a trend towards more and more of these operations, but now we have this data, and yet it has not become sort of the singular way we do the operation. And I think it's an important way to think about when we do studies like this, is sort of early in the diffusion of a new technology so that we have a chance to think about how to right size our adoption.
Well, and I think if you look back at the history of the adoption of laparoscopic cholecystectomy, it's particularly compelling to be able to look at this diffusion of the technology in the way that you all are, because with Lap Chole, it just sort of got adopted by everybody. And the same rigor was not applied to looking at the adoption of it.
Yeah, I mean, I think, and Stan had touched on this before, but the two questions, and this was before Stan and I had practiced, but we can read the papers, and this was a controversial change when we went from open to laparoscopic cholecystectomy. But the innovation was to change the operation from one with a big incision to a smaller one. And the trade-off was that there was an initial uptick in technical injuries that we've, lots of good reasons and lots of work by many in the field have gotten right now. And the innovation here, the question is new technology brought about by robotic surgery going to help us make this an even safer or more efficient or, whatever operation? And the question on our end is, we're not sure that the innovation from laparoscopic to robotic surgery is necessarily manifesting in different outcomes, at least for this procedure.
Right. I certainly hear that talking with my friends who practice as general surgeons and do a lot of these things and are questioning, do I need to change my practice on this, or am I okay where I am? Were there new questions that this work left for the two of you?
I think some of the immediate gut reactions when you think about these results is to think about what would be appropriate barriers and safeguards to ensure that robotic platform is being used safely. And it's certainly something that comes up with sort of any new technology or any new training paradigm when you're trying to think about who should have access to this technology. And we don't think these results should completely exclude a discussion of whether or not the robotic platform is useful for cholecystectomy. There may be a patient population that we just don't know and haven't found in claims data that they may benefit from this novel technology. Currently, there's a lot of opportunities to improve training paradigms on this platform, so including improving simulation and increasing exposure of the platform, both to already practicing surgeons and new trainees, because again, like we saw with laparoscopic cholecystectomy, it was new trainees who focused on safe laparoscopic techniques, but also a lot of outreach to the community of practicing general surgeons to focus on improving outcomes. And currently, it's a bit challenging when the technology is just so expensive. It's not freely available. There are also certain areas where credentialing to use the robot could be a little bit better clarified, and this comes into question for any discussion of credentialing and training paradigms. So some skills overlap between a robotic cholecystectomy and a robotic hepatectomy, for example, in terms of anatomy, but procedural complexity between the two makes apples-to-apples comparisons difficult, and these questions are sort of brought up every time we think about the safe use of a new technology. But I think there's another theme that is a little bit more germane to the use of any novel technology being used in surgery, of sort of thinking about the risk-benefit of a new technique when it's compared to the standard of care. So for laparoscopic cholecystectomy, bowel duct injury rates are very low, and we found that in our paper. And, we talked about it before. It's a huge technical success for our field and should be applauded. And it took a lot of significant effort to disseminate this expertise that was initially developed by these pioneers who used the laparoscopic approach. But how likely would it be for a new technology, a priori, that wasn't specifically designed to reduce bile duct injury, to continue to move the needle lower when the rates are already so low? So, as you've mentioned before from your colleagues, there hasn't been universal acceptance and access to this technology to allow for the expertise to disseminate across our field. So, for, like we mentioned before, technology at this stage, is maybe best to find the appropriate patient population to target so the risk-benefit ratio is a little bit more appropriate. This sort of question was outside the scope of our paper, but it's an important question to think about moving forward.
Yeah, I mean, I think one thing to think about is beyond this procedure in the context of robotic surgery, or even more broadly within surgery, and there's all sorts of new technology everywhere, which is, what problem are we solving for with any new procedure, technique, device? And here, I think the question is, if it is safety that we're pursuing with greater visualization, new instruments, and articulating arms and ways to do the procedure in a different way. If it's safety, then we have to revisit whether the use case here specifically is justified. This is not to say that there aren't great use cases for robotic surgery in other domains. It just may not be one that can be applied as broadly as it is right now. The other question is how robotic cholecystectomy factors into what Stan was touching on, which is how surgeons get proctored and credentialed to then do robotic surgery at their hospitals. And it is a very appealing procedure to use because it is a core competency of any general surgeon to do this procedure. And so it is an extremely appealing operation to use to build up your numbers and get comfortable with robotic surgery. And unfortunately, what we found, particularly for people or hospitals that have done relatively few of these, the rates of bile duct injury are significantly higher. And so there may be other operations for which building up your robotic skills are safer and make more sense in order to then get on to whatever it is you're ultimately hoping to do with robotic surgery. I think we just have to think about what cases are appropriate to, again, get comfortable and build those reps before we are assuming that it would be a safe operation for patients.
I particularly appreciate that on an afternoon that the PGY2 on our clinical service is in a robotic workshop all afternoon.
And you know what? The answer to this is a question that both device makers and surgeons and everyone need to think about, which is, do we need to follow the same progression in robotics that we do in surgical training, which is you do simpler, less complicated cases first, and you work your way up to more technically complicated or multi-step procedures. And if you are able to either open or laparoscopically do some complicated operation, do you need to go back through that entire hierarchy to then do whatever operation you wanted to do robotically? It may not make sense to do that. We've assumed to some extent that that's the right path, and it may be, but this is at least some data to suggest that it may not be the right way to do it. But those are questions that are beyond the scope of this, but this work has definitely opened the door to.
You all have potentially identified as many unanswered questions as you have answered with your work.
Of course.
Typical. Yep.
Dr. Sheetz and Dr. Kalata, thank you both so much for your time today. I really appreciate it.
Thanks for having us. We really appreciate it.
Yeah, thanks again. Appreciate it.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.